research issues and challenges with underrepresented groups in research. Today, we're lucky to have 3 speakers who are going to tell us about issues related to use of large data sets to facilitate our research with underrepresented groups. Our first speaker will be Heather Hsu. She's a pediatric hospitalist and health services research in population health and general academic pediatrics. She's the scientific director of the Boston Medical Center Clinical Data Warehouse, and she's working on linking data silos across the BMC health system in order to promote health equity research. She's going to discuss today using the BMC Clinical Data Warehouse for research with underrepresented groups, and she's going to give us a nice example at the end of her talk about how she did this. Our next speaker is Dr. Bill Adams. He's a professor of pediatrics and an epidemiologist, medical informatician, and practicing pediatrician at BMC. He's also the director of the BU CTSI Biomedical Informatics Core for BU and informatics director for the Boston Health Net. His work and his research focuses on developing and evaluating information technology-based solutions for improving the quality of health and healthcare for people living in Boston, including the Child Health Electronic Health Record, patient-centered information technology, and clinical data warehousing for quality improvement and health disparities research. Today, he's going to speak to us about the BU CTSI informatics tools and resources for special populations. And finally, Dr. Kim Dukes is a research associate professor of biostatistics and the executive director of the Biostatistics and Epidemiology Data Analytics Center at the School of Public Health here at BU. She's worked on and mentored trainees in projects addressing issues involving many underrepresented groups in research, including older adults, children, and individuals with substance use disorders. And today she's going to discuss the Biostatistics and Epidemiology Data Analytics Center, or BDAC services, and the Social Determinants of Health Data Warehouse. So Dr. Hsu, welcome, and we look forward to hearing your presentation. Oh, I should say that we will do the 3 presentations and we will take questions at the end of the 3 presentations. You can go ahead and write questions in the chat if you like, or hold your questions and ask them at the end to whichever speaker you'd like to direct your question to. Thank you.
All right, well, thank you. So today I'm going to talk about using the BMC Clinical Data Warehouse for research with underrepresented groups. Just to start out with a few acronyms and definitions, I'm going to try to speak out the full acronym. I'll probably slip up with EHR, which is Electronic Health Records, and CDW, which is Clinical Data Warehouse, but this is just for your reference if anyone is downloading the slides later. So first, to start out, just what is the BMC Clinical Data Warehouse? So it's a database containing data from multiple sources. The hallmark section of it is current electronic health records data, so EPIC data, but also includes historical data extracted from BMC's multiple legacy clinical systems, as well as some miscellaneous other data sources that are less often used. So all of these different domains of data are related to each other with patient level unique identifiers. And in total, it can be used as a resource for research. So for observational or retrospective studies, for recruitment for prospective studies or surveys, and then finally as a complement to chart review. In thinking about the BMC Clinical Data Warehouse, like I mentioned earlier, the BMC, what I call the mothership, EPIC electronic health records data is really the centerpiece of the clinical data warehouse. And so that includes inpatient data starting in 2014 and outpatient data starting in 2015 and is updated weekly. In addition, we have access to community health center electronic health records data that's updated monthly into the BMC clinical data warehouse, but you need special permission in order to access these data. And then complementary to this, there are some internal departmental sources that are also warehoused in the clinical data warehouse, as well as a tumor registry dating back to the 1980s. And then representing a lot of work, there is these static legacy data. So these are pre-2014, 2015 electronic health records data that are from multiple different sources and represent data that are no longer regularly updated from BMC's older clinical systems. And then in terms of future directions, and Bill may talk about this as well, we are actively working on creating links to Boston Medical Center's HealthNet claims data. So these are the Medicaid data for BMC's plan, as well as some other external data sources, including more census level data on social determinants of health. So what data are currently available in the clinical data warehouse? So there are a few rules of thumb that I generally tell people. So number one is if you can see it in EPIC, it's probably available in the CDW. So things like demographics, home medications, a patient's active problem list or underlying conditions, vital signs, information on healthcare encounters, labs, and then a frequently requested item, which is the social determinants of health screening data, so the Thrive data. Those are all available. Rule of thumb number two is if it's a structured field in EPIC, so not free text, it'll be easier for the clinical data warehouse analyst to pull for you. And if you are able to kind of pinpoint something that you are trying to find, then you can work with the clinical data warehouse analysts in order to locate it. Then rule of thumb number three is just kind of a forewarning that your data will be easier to interpret if you restrict your time frame to either the pre-2014, 2015 legacy data or the post-2014, 2015 data from EPIC, just because the change in the electronic health records creates some artifacts that you will see. So thinking about how to use the BMC clinical data warehouse for health and healthcare disparities research, as well as research on underrepresented groups, there are multiple dimensions of health and healthcare disparities that people are interested in when they're doing their research. Some of these, like age, for example, are very easy to track in electronic health records data. Others are a little bit more nebulous. So thinking about how do you operationalize thinking about opportunity gaps using electronic health records data, that's much more tricky. And then something like socioeconomic status is somewhere in between, where we can operationalize that by thinking about what kind of insurance coverage a patient has, whether it's Medicaid, Medicare, commercial insurance, or if they're uninsured. And so when taking a step back and thinking about developing a research project and thinking about electronic health records data and whether it's the right kind of data to answer your question, just thinking about whether or not your areas of interest will be captured is a good first start. In terms of identifying underrepresented groups in clinical data warehouse data, we have some common requests for identification by a number of these different groups. So we are often requested or get requests for identification of different groups by race or ethnicity, by primary language spoken, or by different underlying conditions or circumstances. So from an underlying condition standpoint, conditions like substance use disorders, sickle cell disease, or pregnancy. And then in terms of circumstances, we have frequent requests for identification of homelessness, nursing home residency, and refugee status. And so all of these things we can come up with ways of identifying in our electronic health records data, but they may have kind of higher or lower fidelity depending on how we how we approach it. So a few important considerations when using these electronic health records data. So as the investigator, you are the one who's going to be making decisions about how to identify and define your study population. So this is something that you need to think about, and the clinical data warehouse analyst can help you operationalize what it is that you want to do. So thinking about this, a good example is, how are you going to use electronic health records data to identify if a patient is pregnant? So that might seem a little bit silly and obvious, but thinking about data that are collected over time, are you going to be using a positive pregnancy test? Are you going to be using a labor and delivery encounter? And so these are the types of things that you need to think about when defining your patient population. And then just another reminder that the data in the clinical data warehouse are really only as good as the source. So this is a screenshot of a patient who has entries for BMC's race and ethnicity fields. And so it says ethnicity, no, not Hispanic or Latino, and then race, Hispanic or Latino. And so this is just one example where if our data analysts were to give you a data set that had this patient whose ethnicity was not Hispanic and race was Hispanic, you would then be in the position of needing to figure out what to do with the data. It's not that the analyst made a mistake, it's that the way that the data are entered don't actually make sense. So how do you access clinical data warehouse data? So there are a number of steps, and I'm just going to walk through each one. So step one is to formulate your research question. So in this, I ask people to ask themselves, what question are you trying to answer? What data will you need to answer that question? Are the electronic health records data going to give you what you need? What is your study design? How are you going to define your study population, exposures and outcomes? And then how are you going to manage and analyze your data? So thinking about this in advance will help you get what you need with less back and forth. And then finally, what permissions do you need to seek? So do you need IRB approval, or do you need permission to access community health center data? So step two is then obtaining your IRB approval or exemption. So this is required to access clinical data warehouse data unless you are requesting simple counts only. And by that, I mean a query along the lines of just wanting to know the number of children ages 12 to 18 years old with sickle cell disease on their active problem list. So something that is completely anonymized and often just used from a prep to research standpoint. Prior to obtaining IRB approval, it is often useful to consult with a clinical data warehouse analyst regarding what data are needed to answer your question. Often a common pitfall is investigators wanting to be able to relate healthcare utilization from a timing standpoint. So was this clinic visit after an emergency room visit, for example, and not realizing that they actually need dates in their IRB application in order to be able to make that kind of relational assessment. And then finally here, just as a resource, if you have questions about permission to access community health center data, you can contact Allison Richmond. And I believe these slides will be available after the presentation to use as a reference. So step three is to complete your clinical data warehouse data access request. And just in thinking about this, just to note that the analyst's role is to help you operationalize your research question and create a data set that you will then manage and analyze. So they are not able to create lots of different derived variables, and will often be giving you the raw data that you then have to kind of create your categorical variables from. You can request a consultation with an analyst by emailing cdw@bmc.org. And then the website with the link to the data request form is there. It's pretty straightforward in terms of the fields that you need to enter. And just once you submit your data access request, you can expect some back and forth with the analyst once your request is submitted, and they'll often ask you clarifying questions and really work with you to make sure that you are requesting exactly what you need in order to answer your research question. In terms of fees, it's generally $75 an hour to cover person time, though with some upfront time offered for free for consultation. If everybody could actually mute, that would be great. And then just also to note that all trainees should have faculty level mentors working with them when they make a data access request. Step 4 is to obtain and analyze your data. Data sets are transferred to investigators via box.com, which BMC maintains as a HIPAA compliant mechanism. And if you discuss any deadlines or target dates with the analyst, then they can give you an estimated turnaround time for your project. In terms of what to expect for data delivery, most requests for data sets take weeks rather than days to fulfill. But straightforward prep to research questions just for simple counts take more like days rather than weeks. But just a plug, and Bill Adams will talk a bit more about this. If you are requesting simple counts, you can consider using some of the self-service tools like I2B2 and Trinetics that he will discuss. So just for a quick example, so this is a research project that characterized the BMC COVID-19 cohort. I can just walk you through how we approached doing this with the clinical data warehouse data. So the objective here was to describe patients with laboratory confirmed SARS-CoV-2 infection that were cared for in inpatient and outpatient settings at BMC. We set a timeline and then defined inclusion criteria as age 18 years or older, laboratory confirmed SARS-CoV-2 infection by PCR and excluding external tests, and that the patient was diagnosed at BMC. And so these are the types of inclusion criteria that you will want to include when you make your data access request that make it clear to the analyst whose data you are asking for. In terms of the methods, so it's just descriptive statistics based on patient characteristics. So age, sex, a combined race, ethnicity, variable, living situation, and then underlying medical conditions. And so underlying medical conditions are found using ICD-10 codes that are linked to a patient's active condition list or encounter diagnosis. We did not use medical history. And then to augment the ICD-10 codes for obesity, we also use measured BMI greater than or equal to 30. And then for substance use disorders, in addition to ICD-10 codes, we also looked for patients with inpatient consults to addiction medicine or a prior outpatient visit for substance use disorder. And then for pregnancy, we classified patients as pregnant if they had a healthcare encounter for COVID or a positive test that occurred within 7 days of the end of pregnancy, either by live birth or abortion or other pregnancy loss. In terms of the outcomes that we looked at, we assigned patients to one of 5 mutually exclusive clinical status categories, looking at those who received exclusively ambulatory care, those who were hospitalized in an inpatient setting but not in the ICU, those in the ICU without mechanical ventilation, those in the ICU with mechanical ventilation, and those who ultimately died. So just some brief results. So we had about 2,700 patients who met the inclusion criteria, and this was the distribution by those clinical status outcomes. We also looked at outcomes by age group. So for each of these statuses, there's a different distribution by age. So you can see that of those who are deceased, the majority of them were in the older age range of 60 years and older. Whereas in the ambulatory group, the majority of those who are not hospitalized were in the younger age groups. We also looked at outcomes by race, ethnicity, as well as frequency of underlying conditions. So that's just a little bit of a taste of what you can do with clinical data warehouse data. And now I will pass it off to Bill Adams, who will also share some of the other tools.
Thank you so much. There is one question in the chat that is it's kind of clarifying something you mentioned. And someone would like to know who enters the race ethnicity data into the EMR, and is it standardized?
That is not standardized, and that's a problem. And it is either the patient is asked a question and somebody enters it, or it is entered on behalf of the patient by whoever is registering them. So it is not standardized. And hence you get the race not, or ethnicity not Hispanic, race Hispanic, and there's also muddling of the difference between race and ethnicity in terms of the two fields.
Thank you.
And I'm happy to answer other questions just in the chat.
For sure, and then that race issue too is dependent on time. It's not great now, but it was much worse in the old days too. So older data is even less precise than modern data. Great, so I'm just gonna take off pretty much where Heather left off and talk about how we leverage that really rich underlying foundational data in the warehouse to do some local and national activities that researchers here at BMC and BUMC could collaborate with us on and do some interesting stuff. So I always start my talks with this slide, which is trying to encourage people to think in a population-based way, that pretty much all of our work is designed to bring together data for as much of the city as Boston as possible. And we have super rich data. So we have a large safety net hospital. We have community health centers that are mostly federally qualified health centers. We actually have EHR data that goes back to 1999, so an over 20-year cohort. As you heard, right now, most of us use Epic, but there are other legacy systems too that if we're able to bring together our collaborating health centers, our legacy data, and next you'll hear from Kim in the future, much richer data about where people live, we will truly have a framework for doing population health in Boston, and also in a way that we could collaborate with others across the country. So at least for the CTSI informatics group, our vision is to make data much more accessible, but be absolutely meticulous about protecting privacy, to bring together the broadest possible array of health data available for researchers. So not just what's in the EHR, but information about communities and places where people live and the quality of the air that they breathe. All those things are really interesting to us. We want to provide tools where researchers can focus on questions more than queries, so that you don't have to be a computer programmer to start to make sense of data. And we want to provide data and tools that are standardized so that we can ask the same question in Boston, in Los Angeles or Chicago, or anybody else who has spent the time to transform their local data into standardized frameworks. And finally, advancing health equity is foundational to everything we do. So we won't have time to go into every detail here, but this is the high-level framework for clinical data resources and networks for the BU-BMC research community. And you heard a lot from Heather about the CDW, which is still pretty much the primary source for data that most researchers here use. I also want to remind folks, though, that we have expert faculty and analysts who can meet with folks and answer questions and brainstorm about actual questions, but also feasibility of data, and consult around new data approaches like machine learning and AI type strategies for actually using the data. We have a bunch of tools, and I'm going to talk about a few of them, but there's self-service web clients, there's the ability to get data extracts, and some self-service analytics, and then we have some more advanced hardware solutions for folks who want to do more sophisticated analyses. And then we plug in our data into national networks, of which I'm going to talk about a couple. And underlying all those systems that we're going to talk about is I2B2, which is a de-identified transformation of CDW data into standardized concepts, which I'll tell you a little bit more in a second. But currently we have almost 2 million patients in our de-identified repository, I2B2 repository, and I think now approaching 2 billion facts about those people. And at the end, I'll actually provide some links where you can learn more in depth on some of these things, because in the short time we have, I'm not going to be able to touch on everything. But I2B2 stands for Informatics for Integrating Biology with the Bedside. It's open source software based on the Mass General Research Patient Data Repository. So this is open source software that was shared by MGH starting about 10 or 12 years ago and is widely used across the translational research community. And the idea is that you can create through software modules or cells that can be linked together. At the foundation of the system is a de-identified clinical data repository, data linked to standardized vocabularies, and then some tools to actually access that data. And we've actually been using I2B2 at BMC and BUMC since 2009, since the very beginning of the CTSI. Although I would say it's finally being used more widely because of the new tools that can leverage I2B2 data to make data more accessible and usable. So this is a high-level view of where our data comes from for I2B2. We bring in EHR data from multiple sites, Boston Medical Center and its affiliated health centers. We spend a lot of time in this thing we call the staging area, where we take identifiers for individuals across the network and create a master patient index that allows us to link clinical data from Boston Medical Center with community health centers. We do a lot of data cleaning, and then we do a lot of data mapping. So LOINC is the standard way to represent lab results. CPTs, probably people have heard about. RxNorm is how you represent labs. ICD-9 and 10 are diagnoses, and SNOMED is a mega vocabulary too. So once we can map those terms to those standard concepts, we become in a much better position to work with other folks and start to collaborate. And we push that into a very simple data system that is really just 3 big tables: a list of people, de-identified people, facts about those people, and definitions of those facts. So it's really easy to put just about any type of data into I2B2. It's not always easy to make sense of that data, and that's where the tools come in. And then I think, as Heather referenced as well, people can use I2B2 data from BMC in a IRB approved manner, or if it's only the aggregate queries through a self-service portal. And then if we want to use the full system with community health center data, that has a separate governance process that we can help you navigate as well. So that's I2B2. I would say over the past 10 years, we've spent a lot of time pulling together these data, and it's been relatively underused by the research community. So about a year ago, we joined a collaboration with Trinetics, which is a private for-profit company that ingests a variety of standard type data platform data, of which I2B2 is one, and there are 3 others that can be used to collaborate with Trinetics. And they bring that data in and link it to the data from many other sites across the country to start providing much better, richer access through self-service tools. They also share these data in a de-identified way with pharmaceutical companies that are invited to reach out to us in a blinded way to collaborate on clinical trials. So it's a win-win. We get a software platform that can help us use our own data, and we potentially get new research opportunities to collaborate with pharma to investigate new therapies. And I'm just going to tell you just a little bit about Trinetics, but currently there are over 150 healthcare organizations contributing to Trinetics. There are a huge number of patients in the system. This is a listing just as of June, and it's grown even substantially since then. And there's also a fair number of international collaborators as well. So it's quite a large and growing data system. Currently, only people with a BMC username and password can log in, a BMC email address, but we're working on building a framework where BU collaborators can join us too, especially from the medical campus. And so there'll be more coming on that in the not too distant future. But currently, Trinetics uses the Active Directory accounts at BMC. So any researcher who has human subjects research training and a BMC username and password can request access to this system. And we don't have time to do a whole in-depth demo of Trinetics, but you can see here, this is a very simple query of things that the patient must have. And I chose diabetes and hemoglobin A1C greater than or equal to 6, which is abnormal. So this would be a list of people who have this condition. And then I'm including everyone in the network, but I can actually go here and broaden this query too to include 150 other HCOs and dramatically increase the population. And I can build a query for BMC and then I can redirect it towards the overall network. And what you can do is a whole bunch of features, which again, I don't have time to talk about, but this simple one is once you run that query and get a count of your 40 or 50,000 patients, you can begin to explore that cohort. And so, you know, gender is one dimension of a special population, and this makes it really easy to see how your cohort balance is different, that there are more females who are older and more males who are younger compared to the females. And then you can also do all kinds of other things like explore the duration of the data that's in the system and understand what's going on within the data as well. And there is a link at the end to an online demo that we did of the actual Trinetics system last fall, and I'll encourage you to look at that too, because we just don't have time. There's also, though, some really nice new features in Trinetics that are going to make it really easy to compare populations. And this is where you can define cohorts of special populations and compare them to either not special or a different way of being special, and begin to do a self-service exploration of health and healthcare. So one way is you can look at a single cohort and analyze outcomes for that cohort based on exposures or treatment pathways. And then it also makes it really easy to compare two different cohorts against each other. So this group and this group and rates of outcomes in the future. And using this self-service tool, you can build and compare outcomes for different cohorts, which, you know, I think we're just beginning to use this tool, but I think it's going to provide a lot of rich functionality for the work that we want to do, and lower the bar to getting access and exploration of clinical data. So we talked about Trinetics. Now that I consider both a local resource, but also a national resource, because we can see data that's pooled for all 150 other HCOs that have agreed to collaborate. Actually, I think it's only 45 are sharing all their data centrally. But we also use our I2B2 data within the ACT network, the Accrual to Clinical Trials network, where their primary focus is on recruiting cohorts across the country at different CTSAs. And I'm going to show you a quick example of that. And we also share our I2B2 data with the National Cohort Collaborative, the NC3 Collaborative, which is an NIH-sponsored national data system that's also available to BU and BMC researchers if you're interested. And we are looking to join the Odyssey or OMOP community too. And I know Heather put out a bunch of acronyms at the beginning, and I've just thrown out a bunch more, but that's informatics. We're just full of acronyms. But this is a really rich way of looking at health services data, which hopefully will become available in the coming year to our BUMC researchers. So a little bit about the ACT network. It's a collaboration of 35 or 40 different I2B2 instances across the country. And what you can do is define a cohort, and we can help you do this. Send that cohort out, that query out in real time across the country, and within about 5 minutes, get counts of patients. This was a simple count of patients with diabetes mellitus. And for the BMC database, we got 83,000, but you could pretty quickly find patients with rare conditions. A whole bunch of special populations could be explored through this tool as well to identify potential collaborators that you might want to reach out to and work with, and partners is included here for sure, as well as children's hospitals. So there's tools that could be used, and we would love to help you use them. And then just to wrap up, the N3C collaborative also pools data from multiple sites across the country. I believe there's 50 health systems currently contributing, with another 40 on deck. And you can actually, we have now approval for any BU or BMC researcher under institutional IRB data use agreements to use the system with an IRB approval. So we would love to help you explore that as well. It's a cloud-based analytic space supported by Palantir, a well-known technology company that allows investigators to come in and mine all kinds of data on a national scale for COVID. So just to wrap up, we invite you to request a consultation from the CTSI at any time. The website is here, and you can just put in an online request and people will get back to you. We also have 3 online YouTube presentations. One was this summer that I did around an overview of all the informatics tools, which goes into more depth than I did today. A deeper dive into Trinetics, and then a demo of actually using Trinetics. So don't hesitate to reach out and contact us. Nicholas works closely with me, and we would be very happy to help you with any of your research data needs.
Thank you so much, Bill. I think Heather has been doing a fantastic job answering questions in the chat. So we'll move right on and hear Kim's presentation.
Hi, everybody.
I think we need you to turn up your speaker or microphone or something. We can't quite hear you.
Can you hear me now?
Keep going.
Just distance, yeah.
How about now?
It's a little better.
Okay, maybe I should. Is this better?
Oh, much better.
Okay.
Better.
Okay, great. That's the first time I've ever been told I'm too quiet, so that's good. So I wanted to talk a little bit about the Biostatistics and Epidemiology Data Analytics Center's capabilities and a little bit about the history. So it was originally founded in 1984 as the Data Coordinating Center, and it was rebranded in 2018 to the BDAC. We provide centralized research services to BU investigators, government, and industry collaborators. We may go after a grant or a contract on our own, or we may partner. Typically, we partner with BMC, or other people, other collaborators, and go in on a funding together. Our core competencies, or our functional service areas, are now we do a lot more project management, where we have internal and external facing management. We are more involved in the regulatory affairs in terms of the data use agreements, IRB agreements. We provide a lot of data management where we do extract, transform, and load processes, where we develop electronic data capture systems, or we receive secondary data from something like the EMR systems that have been described. We also are doing data sciences, more big data approaches using the cluster. We do a lot of geospatial analyses. The data sciences and the geospatial analyses are new capabilities. And then we do reporting in addition to our static reports that we provided in the previously. We actually do a lot more interactive dashboards through Power BI or custom solutions. And all of our reporting for typical trials, either clinical trials or observational studies, we always do safety, data management, and statistical reporting, as well as data monitoring committee reporting for interim looks at the data. We have built up, we work with the Biostat and the Epidemiology departments in the School of Public Health. We are part of the School of Public Health. But we also have our own staff that are able to lead some of those investigations. In general, like I had mentioned, we usually partner with BU faculty and staff, and then we're fortunate to be able to use the centralized computing and security services offered through BU IS&T. We currently have, actually it's 45 employees, we have 2 faculty members and 5 students, and we have several postdocs that are in our group from the Biostat department and global health, and EH, the environmental health. We have 5 basic core functions that group some of the functional service requirements that I had listed on the prior slide. And we obviously have administrative operations and a business development arm. I'm going to talk a little bit about a project that is more big data science. And one thing that I want to point out is that we've been talking about social determinants of health. Heather had mentioned that in her presentation. And one thing that I will say here is that when people think about social determinants of health, you can think about them at the individual level, but you can also think about them in terms of the community for which you live, work, or play. And so the warehouse that we're developing, or what some of the work we're doing, is we're looking at individual reports of disparity, but as well as looking at the environmental reports of severity. And that's what I'm going to be talking about. So it's individual versus census tract or county or community or zip code. So I'm going to be focusing more not on the individual, but at a given geospatial level, and what that information could entail that provides additional information other than the individual report. So in 2019, we started a really great collaboration. It's an industry collaboration, and it has been terrific, with this company called ShareCare. And originally what we're doing is we're looking at the health and well-being as a function of their community surroundings. We're doing community-based intervention projects. They're called BZP Blue Zones projects, where we look at gaps in care and how to improve a community's health by providing more access to foods and care. And then we obviously are disseminating the research findings through reports through the ShareCare app and through customer engagements that we have. Historically, Gallup had done a lot of the well-being index surveys for a period of 10 years, and they had done either phone or mail-based surveys, and that in that process, over that 10-year period of time, they've collected about 3 million surveys, and they've had about 80 or more peer-reviewed publications. And the way that the reports looked on the right is they would rank states, and they would be able to rank metropolitan statistical areas based on this well-being score. And they had 5 constructs or 5 pillars of health, which were social, physical, community, purpose, and financial. So they would mail a survey, they would call somebody, they would have people answer these questions, they would take these questions, they would, to represent the United States, and do mailings every month, and then they would rank states on their performance in these particular constructs. In 2017, ShareCare acquired that main company, and what they had been doing was this real age test, which adds additional information to your well-being, but it also takes into account metrics such as your lifestyle, health history, and any other biometrics about you to help, what they say, predict mortality. So if you have good health habits and you're actually 38, your real age may be 35. And if you don't have great health habits, it might be 43. And so it's a digital way to look at how you're taking into many factors, not just your report of your health. And so they started this, and they had about 43 million users using the app. And they thought, well, how can we capitalize on this information instead of doing the traditional mail surveys, phone surveys? And so that's where we came in, and we have been working with them to use this real age, this well-being, and then I'll talk a little bit about our SDOH indices. So what we have is we have been collecting for the whole United States a bunch of spatial SDOH variables. So again, we have them at the tract level, we have them available at the zip code level, we have them available at the county. And what we've done is, and I'm sorry, this is small, we've done some crosswalks so we can easily move data from one unit to another. And so on the right-hand side, we have collected data, educational and access, healthcare, social and community measures, neighborhood and environment, and economic, and economic factors. And we've collected a lot of this information from the American Community Survey, the American Housing Survey, the CDC, the USDA. On the left-hand side of the data, on the left-hand side of the orange pictures, we've actually created some geospatial derived variables to look at air pollution quality. We've taken a look at meteorology, where we've looked at temperature and participation. We can get that in real time every day, as well as some information that we've done in terms of the built environment, green space, transportation, access to grocery stores through MRAFI and other public data sources, and for purchase. So what we did was we took all of these measures. So on the left-hand side, we actually had over 600 items, and we selected about 59 items based on originally the CDC Healthy People, and that should say healthy, not health people, Healthy People 2020 framework. And so as you can see there, there's 5 constructs, and within each of those constructs, we had 59 items that we selected. And then what we wanted to do was we wanted to find the most parsimonious model, where we did a confirmatory analysis, where we ended up reducing these 59 items to 17 items that get at these health access, resource access, economic security, housing and transportation, and food access. We actually have all of this data available at the tract level and at the county level, and then the zip, and then except with the exception of resource access. So we're continually building on this and refining our models, validating our models, and have all of this data, these 600 items, plus all of these subscales, sub-indices available for every state in the United States. I mean, every county in the United States at a minimum. So there's about 3,100 of them. So what we do is every year we create these rankings where we look at the WBI and the 5 pillars of WBI and the 5 pillars of social determinants of the health, and we combine them, and we actually create rankings about who's in the top versus the bottom quintiles of health. And as you can see on the left-hand side, and I'm sorry, that's a abbreviation, that's a well-being index. This is a patient report of well-being. And you can see as you go from left to right, which is the community well-being index, which incorporates well-being and the social determinants of health at a spatial scale, you can see that by incorporating that there is shift in terms of how states do. So by incorporating it, it changes their rankings. And so this is like a very high level analysis, but there are a lot of intricate things that are done, and a lot of data that are available that can be used for analysis that could be linked to the research that you all might be doing. Just quickly, we have a process for ingestion, an automatic process of ingestion. This talks a little bit about it. We have data dictionaries, and then who has access to it. And then there is a committee that lets the data out. We're working with other academic partners. And we have our data science core at BDAC. We have a geospatial core with EHS at BUSPH, so the environmental health group at the School of Public Health. And then we have a subcommittee, and then we get data from industry partners. We purchase data, so we eventually want to try to get Medicare and Medicaid data as well as other data to help validate our indices. And then we work with other academic partners in developing this warehouse and potentially publishing on it. Last slide is how to work with BDAC. Our services are available for BU and BMC investigators. So if you wanted a couple of hours of consulting with how to potentially access the data, or you had questions about data management or statistical analysis, you can contact CTSI directly. We're allowed to provide 2 free consulting hours to anybody who wants them. It usually goes through the CTSI, and I could add the link there that Bill had already provided, or you can contact BDAC directly and we'll forward the request to CTSI. And then after those additional hours, they'll either be approved by CTSI or will be paid by the investigator. We have been very successful in working with many BMC and BUMC investigators and helping them put together proposals and supporting data management, statistical reporting needs, as well as all of this other functional service areas that I had just specified. This is the team, the CWBI team, and I just wanted to say thank you.
Thank you so much, Kim. And that was a wonderful overview from Heather, Bill, and Kim about the sources of data available to researchers on the BU Medical Campus. And we'll take any questions that you have now. I know a number have been answered in the chat, but if others have come up, please unmute yourself and ask now or type away in the chat. So maybe this is somewhat overwhelming for those of us who are looking at these large data sets and thinking, where do I get started? I thought that our speakers did a nice job of setting out where you start, but can you give us an idea of which of you should we, or which system should one go to first, and how would you make that decision? Does anyone want to tackle that?
I can start. I think, you know, there's a number of us who can help folks talk through their ideas. And I think the great thing about the 3 talks that you heard today is they're not particularly siloed. Each of us wants to find customers and refer each other customers and to be as successful as possible. So the truth is, depending on your question, some tools are going to be better than others. And I think reach out to any of us and we will direct you to the person. I think usually within about 10 or 15 minutes, if I talk to someone about what they're trying to do, I can get a pretty good sense for where's the best place to start to dig deeper. And so, yeah, I mean, I think it is tricky. It's hard to know where to get started. And then it's also really hard to know, if you're not a data scientist, how to get across the finish line. And we can help you with both of those things, because I think there's a real recognition within our research community that we have super rich data, but we still need to level up too and help people actually get information and knowledge from the data once we deliver it. So that's my perspective. So reach out to us, and I don't know, what do you guys think?
I agree with Bill in terms of when I talk to folks, I can usually get an idea within the first few minutes of chatting about an idea of kind of what scale we're talking about in terms of what data would serve the question well. I think that it's really important to start with a question that is well formed, and so sometimes choosing a data source first will kind of put the cart before the horse a little bit. And so like, for example, if you really wanted to be able to do a project using Trinetics, then you would be needing to like really get into understanding like what are the pros and cons of Trinetics and what is it capable of before formulating your question. But if you came with a question to chat with me or Bill or Kim, then we might be able to help you really center that question in the work that you're doing, rather than going the other way around.
And I just had one comment about that. I think for us, it would be for the work that I presented in terms of the warehouse, it would just be making a request. But I will say that in BDAC, there are a lot of people that are technically savvy at how to work with data, how to handle data, how you should set up a study. Everybody thinks it's easy to create a questionnaire, all of those kind of things. I think it's always good to get, if you're doing a study where you're collecting primary data or even trying to use it or report on it, it's always good just to touch base with us, just so that we can help you figure out like how to either ask a question or surveys that have already been done that are available, or if you're trying to do a report about looking at the quality of the data first, and you know what data management steps you might need to help you with your process. Right? Because just because you want some data doesn't necessarily mean that it will be there, and how to best analyze it.
That's really helpful. And in the chat, there's some dialogue going on about whether the request should be made formally through either the clinical data warehouse or to CTSI. And Heather has generously offered her personal email. I'm not sure if Bill and Kim are saying the same, but certainly reach out through the clinical data warehouse email address, the CTSI request email address, and I'm sure Bill or Kim would be willing to speak with you briefly, at least to get you pointed in the right direction.
Yeah, I gave the BDAC proposal one, and it's the best to contact them first, because then they'll make sure that I follow up in a timely fashion. So I put their email address, and that's like the best way to get a hold of me, because they'll help schedule that follow up.
And yeah, two things: don't be discouraged and or embarrassed, because our CTSI is actually funded to do this type of work and encourage this type of work, and so it's in our interest to have you be successful. And two, sometimes we will route you through the more formal mechanisms so that we can track these things, because it's part of our measurement and evaluation for the CTSI. So if we do, don't be offended, but you can always start out reaching out directly, and we'll help you get to where you need to be.
That's terrific. Well, it's at the top of the hour. I want to thank Heather and Bill and Kim for such a terrific presentation and for their generosity and being available to all of us. And I hope this has given all of us a better sense of how we can work with our questions and our data. These presentations are recorded and will be available on the CTSI website by the end of the week. Did you have something else to say, Bill?
And thank you, Nicholas and Elizabeth, for pulling this all together.
Yeah.
All right. Thank you, everyone. And have a great afternoon and good luck with your projects. Bye-bye.